There's really two main toxicities that we're most concerned with. One is cytokine release syndrome, which is really a state of inflammation driven by various cytokines, IL-6 being one of the major cytokines that drives that process. The other main toxicity that we're concerned with is neurotoxicity, and in fact, with some of the earlier products cerebral edema has been an issue that's led to actually deaths with some of the products. More recently, we haven't seen as many of those specific events occur, but certainly CRS, or cytokine release syndrome, and neurotoxicity are the big issues. It's not clear what the mechanism is for neurotoxicity, but as I mentioned, it's sort of the inflammatory milieu, cytokine production is what drives CRS. And so when we think about patient selection, there really needs to be an understanding of the fact that we need to pick patients for CAR T cells that have relatively preserved organ function such that they can withstand those toxicities with minimal neurologic comorbidities. There's some other issues with respect to limitations for CAR T cell therapy, and that includes the need for adequate hematopoietic reserve so that we can actually collect adequate CAR T cell product. And there's, with respect to their disease needs to be relatively stable moving into CAR T cell therapy because of the logistics of manufacturing. It can take anywhere from 3 to 6 weeks for CAR T cell products to be manufactured, and so we have to ensure that patients can actually be bridged in a way where they can actually receive their CAR T cell product.